Hi everyone, my name is Ash. I'm an emergency physician working in Changi General Hospital, and I have here with me Prof Goh Siang Hiong. Now he's a person that needs no further introduction. He gave this wonderful lecture during our recent annual scientific meeting, and we are just spending this time to record this session together. And so Prof, please go ahead and introduce yourself.
Yeah, hi. Thanks, Ash. I'm a senior consultant at the emergency department here. I've always had an interest in teaching because I believe that if you teach well, you can improve patient safety. But after a while, I realized that even though we are teaching things, sometimes mistakes still happen. And that made me start to think about how doctors think. And recently, I gave this talk at the invitation of Society for Emergency Medicine in Singapore. This was at Kutepot Hospital just in April. So I guess that it's a good time as any to elaborate on what on how physicians think and how we can improve our accuracy and safety.
Right.
So the talk, when I first given the talk, it was like right on target in a blink, and I thought, really? It's not always possible to be right on target in a blink. I know from my own experience that when it comes to orthopedic cases, I'm about 95% accurate.
Okay, that's not too bad.
Yeah. Then when it comes to surgical, again, it comes up to about 75%. Okay, compared with the doctors in the ward. But when it came down to medical cases, it dropped to about 60%. And for geriatric patients, it dropped to a very dismal 40%.
Okay, that's
and I think most of us, if you work and you go and audit your admissions, it is around there. All right. So let us start, and let me show you what I mean. Okay, everyone always thinks that physical diagnosis right on target in a blink are the ones that are easiest. Okay, so these are some snapshots of common cases we see in the ED. Alright, so Ash, let's start off. Okay, now you and I know, right? What is this patient having?
right. This man has anterior shoulder dislocation.
Right, and we can tell this because he has the loss of the classic curvature of the greater tuberosity. Alright, the the joint here is protruding out, so it's a classical squaring.
That's
okay,
right.
and if you want to confirm, you can always ask the patient, is there any numbness here? And the patient said, yes, there's numbness. Then it's an axillary nerve injury, right?
Right.
Right. Okay, another one. This Malay man had come in and said, my face started to swell after I took some crab stick.
Right. So that's angioedema.
Right.
Anaphylaxis.
Correct. Classical, lip swelling, tongue swelling, and of course our concern is if he goes to the stridor, we should intubate him early.
Right.
Okay, and here's another classic thinner fork deformity after a fall on outstretched hand.
So Colles fracture.
Right. Old woman coming in after a trip and a fall, and she can no longer walk on the right hip pain.
Right. So that's the hip fractures.
Yep. Shortened, externally rotated, and abducted. Okay. This is a patient, and this is a normal person's hand. And this patient had come in complaining of tingling sensations in the hand. Alright.
Right. So that's likely carpal tunnel syndrome.
Yes.
And this hand is really big, so I'm going to suspect acromegaly.
Correct. So again, you don't have to do any special tests. You just test him on Tinel sign is positive. You look at him, and sure enough, he had the classic cause features. I compared his IC, the photograph on his IC, which was like about 20 years ago, and you can see a marked difference in the facial appearance. This is a man who complained of itchy eyes and then nodules under the eyelids, and he's a chronic contact lens wearer.
Right, so that's giant cell conjunctivitis.
Giant papillary
Giant
conjunctivitis.
papillary, that's
right.
right.
Okay. From chronic irritation. Now, another one, patient comes in with chest pain, crushing chest pain.
Right, so that's quite classic. That's an inferior ST elevation MI. Yeah, inferior posterior actually.
That's right. And knowing this, you just give him the goodies, antiplatelet agents, press the button for PCI, activate the lab, and off he goes.
That's right.
And how about this? A man who complains of fever and sore throat. Then after that, find it increasingly difficult to breathe.
Yeah, so that's prevertebral swelling, retropharyngeal abscess.
Correct. And a man who was punched over the right cheek, and after that, he complained of double vision.
Right, so that's, I think, is the teardrop sign.
Correct.
Yeah.
Once again, you have hit the nail on the head. And for this teardrop sign, we know it's a block fracture, and we
Right.
just refer to the to the plastics.
Right.
And something more challenging. This example of a patient with small bowel obstruction after having right hypochondrial pain for the previous few weeks.
Right, so dense opacity in the pelvis. So given the history of right hypochondrial pain, we gotta suspect that that's a large gallstone that has dropped into the small bowel.
That's right.
So it's gallstone ileus.
Correct. And you know this more, and you know this can be confirmed by looking at the you see these streaks of air in the liver shadow.
Right, right. Yeah.
That's aerobilia.
Okay.
So you and I, between us, we've got more than 40 years of experience in the ED.
Okay.
Okay. So and so far all these have been physical diagnoses, right? Whether it's imaging, whether it's physical signs, whether it is a classical from the history, right? So this is a patient who had fell on an outstretched hand, and when it fell on an outstretched hand, you just press one point, and the point was pain in an abdominal staff box.
Right.
Right? So straight away you would order a scaphoid series. And what do we see here?
So it looks like there's a fracture in the waist of the scaphoid bone. It's quite obvious.
Correct. Actually, this X-ray was missed by a junior.
Okay.
Okay. Because the junior was like, okay, why did the senior do a X-ray? Then when he looked at it, he said, I don't see much. And then he sent it to the senior, who fortunately vetted it here. In Changi here, we vet all our X-rays.
Yeah, we do.
Yeah. And the senior said, I am looking specifically for a scaphoid fracture. And if you don't look for it, like the MO, he did not look for it, then of course he missed it.
Right, right.
Okay. Now, if you think that you can only make spot diagnosis, right on target from just physical signs, from images, from ECGs, well, actually, would you agree with me that we can also make spot diagnosis from the history?
Yes,
Yes,
certainly.
Okay, and here is where I want to tell you an interesting story. So one day I was at a cell group of my Catholic church, and Father Fred came over and said, Peter, that's me, my Catholic name. Peter, come and listen to this. Okay, that time we are talking about how Jesus healed the paralytic people, healed the paralytics.
That's right.
Right. So my friend L, he was telling his people sharing his group, he had woken up at about 4 a.m. and then he couldn't move. He just couldn't get out of the bed at all, right? So an L's testimony was like, he prayed to God to help, and then 3 hours later he found that he could walk again. And this was actually witnessed by his wife V, and his wife said, it's very true. He was lying in bed. We were all so scared, but he was still awake and talking. So we were hesitating, wondering whether to call for the ambulance or not. Then after a while, he improved. Okay, so when I took this history, when I listened to this history, then I was looking across the room, and I noticed that L has something in the neck. Okay, so what do you think I was looking for?
I'm gonna guess a goiter.
Yes, and he has a goiter. So I went over to L, introduced myself, and Father Fred said, Peter's a doctor here, so I just measured a pulse rate, and he had resting tachycardia.
Right.
Right. So on Monday, he came to the ED, we did a thoracic function test, and we confirmed that this was a case of
Thyrotoxicosis. So it's periodic paralysis.
That's right. So L was saying, you mean God didn't save me? But then Father Fred said, well, no, but God sent Peter to see you. And here's another story from my army days. Just bear with me for a while.
Okay.
So I was a medical officer in Pulau Tekong, right? And I know this boy, he's having discipline problems since he came to the recruit stage. Almost every week he would come to my medical center and ask for MC, and in fact, he wanted to take MC for backache before a field camp that very Monday. So of course I examined him. There was nothing much. So 4 days later, they called me in the late afternoon and told me, Captain Goh, we've got this army recruit. And I said, looked at his name. I know this boy. Yeah. We arrested him and charged him with assaulting an officer while doing the field camp. He argued an officer, then pushed the officer down. Then after that, they arrested him. So he was now in the camp's detention cell. All right. So, if you know in the army, right, every time before you get charged and get thrown to the detention barracks, we MOs had to FFI him.
That's right. That's right. Mm-hmm.
So I walked into the cell block, went into the small jail. I looked at him, and he wasn't his usual self. He was struggling with the restraints. He was breathless and shouting away and panting. But usually even though he was trying to take MC, he was always like quite civil, jovial, polite. So, in fact, he was downright abusive and did not cooperate with me at all. Not his usual self. Okay. Now I had just finished reading the Oxford textbook of medicine.
Okay.
Back in those days, I was an internal medicine trainee. I was trying to pass my part 1 in the camp.
Right.
In the army days. So that morning I was reading about the differentials of a confusional state. So this was exactly that same list.
Okay, it's a very long list.
Long list. Right. So I said, I can't do this. If I want to investigate, I'm going to have to evacuate him back to Changi Hospital.
Right. Mm-hmm.
Right. Then I was like, let's just have a look. So then, while walking back to the medical center to collect my equipment, I said, wow, the sun is really hot today. Then I looked at it and then I quickly turned back to the lieutenant, who was accompanying him. I said, what were you guys doing in the field camp? Oh, we are doing trench digging. In the jungle.
Okay. Mm-hmm.
So quickly, I took my medics, the rectal thermometer. We went into a cell block, took his rectal temperature against his will, and it was 41.4.
Okay, now we know what's going on.
Right, his stroke. So we evacuated him back, put him in the body cooling unit. His temperature came back to normal, and he started to be more alert and conscious. Okay, so the lieutenant asked, so can we charge him? I said, I'm afraid not. You can't charge him. Right, you can't charge him anymore because he's a confusional state.
Right.
Okay. Now, to many of the juniors, when they look at this, they're like, how did Dr. Ash, how do all these consultants do it? These are like spot diagnoses, right? So the more junior you are, especially medical students who rotate through our department, a lot of them say, how do you know this? It's like a spot diagnosis, and they are very impressed.
Right.
Okay, let's look at how medical students are trained. And then as we go along, how we ourselves start to organize our knowledge. So in medical student days, right, you bring us to the bedside. We'll talk to the patient, take a history. And sometimes we have to go through, like history of pain, right? The 10 questions on pain.
That's right.
Yeah, when, how, where does it radiate, the nature, blah, blah, blah. Okay. From there, we work out a list of differentials. We examine the patient to rule in or out some of them. We do the relevant tests, and then we come to one or two which we think are most likely, and we present to the tutor. And the tutor always tell us, when you hear hoofbeats, think horses, not zebras. Because our aim was to avoid rampant investigations, right? And this one you and I know. Whenever we get new MOs that come in, especially those PGY ones, they'll be ordering a lot of investigations. And some of them we felt weren't really needed. Okay. Then when you start to become a house officer and medical officer, remember all those algorithms we love, right? Yeah. Step 1, for instance, this patient with low back pain. Step 1, what do we do? Step 2, step 3, step 4. So everything was a flow diagram. Okay. So here's another example for lower limb pain, non-traumatic. If there's a trauma, you go this way. There's no trauma, you go this way.
Right.
Right. But again, as we went more and more senior, we also realized that algorithms also don't work. Why?
Yeah, well, probably because you have to choose the right algorithm to begin with, and atypical presentations, then, it's not helpful.
Correct, right. For example, the lower back pain,
Right.
They go through orthopedic. But you know that sometimes if you don't palpate the abdomen, you'll miss a triple A.
That's right.
You don't ask a woman for a gynecological history, you could have missed ovarian cancer or UV prolapse.
That's right.
So again, we abandoned it. And we then started to develop our own, what we call heuristics. After all, I remember those cases we discussed, it was all heuristics. Heuristics there are many definitions for it. It's experience-based techniques for problem solving, learning and discovery. Just the term experience means you have to work hard at it in order to gain the knowledge.
That's right.
Right. So for example, I like this diagram. You are going along, you have one differential diagnosis, it doesn't work, you go to another one and another one and another one until you reach it. But if you are an experienced beetle, you just go from point A all the way to point B straight away. Right? You hit the target. Okay? And Anisimov define it as a shortcut that's usually unconscious, or a rule of thumb that allows you to process a large amount of information in a short amount of time. Okay? And I would recommend you go to this website. You are still there when I last checked on it.
Okay.
Then when there's a lot of information, mental shortcuts will help you cut through and get to the point. So the important thing is that you have to ignore part of the information, consciously ignore part of the information. Okay. So rather than weigh all the options, it can actually lead to a more accurate diagnosis in a more efficient manner.
Right.
All right, and again, it goes through the rules. Common things occur commonly, rare things occur rarely, but at the same time, uncommon manifestations of common things are still more common than common manifestations of rare things.
Right.
This is courtesy of Prof Tiru. I learned this from him. He was a dermatologist back then. Okay, so therefore, if you ever have a chance to watch a senior working, you realize that all use pattern recognition, illness scripts, heuristics, so that you can process our patients very quickly.
Right.
And of course, all these are highly personal. Actually, there's nothing more I would love to share my internal library of heuristics. But if you ask me to sit down and write it out, it's quite impossible.
No, we can't do it.
Yeah. That's why there's very little research on heuristics. Because you can't do it like a randomized controlled trial. People always think it's a rule of thumb. So a lot of people never did much study on it.
Right.
Very uncontrolled.
That's right.
Okay, so and it corresponds to the way we learn, right? Remember, as a medical student, you have to when I was a medical student, I saw a lot of patients. I did a lot of studying. I gathered a lot of data by reading thick textbooks. And yet, when I started out, my diagnostic accuracy was really bad. But now, as you are more senior, I'll be first to admit that with all my admin duties, I don't have time to read as much as I like. Yet, our diagnostic accuracy is much better.
That's true.
Right? For the amount of testing that we do.
Yep.
Because this is the way we mature. And as we mature, so do the way we solve problems. Same also. Okay? The more you recognize a pattern, the more accurate you be. And in fact, you can forward think. Forward think means I can anticipate what I want to do next.
Right.
Let me give you this example. A very common problem whenever a senior looks at a computer system, right? And there's a triage list, right? So when you have a triage list as a senior, I want to pick out certain cases where I want to review it with the medical officer, or I want to see this faster because it could be a danger. Okay, so I had to leave the name in because of we need to know the sex.
All right.
And we have the age. Okay, let's take it one by one. So Ash, let's look at this.
Okay.
You are seeing this Lin Go, a lady, right? 36 years old. MEF, that means a police case. Pain over the chin, left elbow, left wrist after a scuffle. So what do you think of this case?
Nothing much actually.
Yeah, nothing
Minor
much.
injuries.
Right, minor injuries. The only tedium part is to record it.
Right.
So you would ignore it, right?
Okay.
Nozana Binte Muhammad, okay, a 42-year-old lady, giddiness, vomiting for 1 week. Seen a doctor but still not better. And you notice that, 42 years old, she's still possibly menstruating. So while it could be still giddiness and vomiting, what other concerns would we think about?
Just the 1 week history kinds of pop out. Something that is ongoing for 1 week is certainly concerning.
Right.
Can be many things still. Yeah.
Yeah. So you would ask for additional things like, is there headache as well? Is there cranial deficit?
Yeah.
And
Pregnancy.
because she's still, pregnancy.
Absolutely.
Okay. Sky Tan, 23-year-old. Headache for 2 days, cough with yellow phlegm. And you look at it, NS boy.
Right, in the age group.
Right. So first thing is you click on the past records and we see he's a frequent attender. We'll probably drop him from our radar, right?
Right.
Right. Now, 49-year-old Chinese man, left-sided chest pain on and off for 1 month. This one we want to do an ECG.
Yes.
And if ECG is normal, you'll probably also drop off our radar, right?
Possibly. Yep.
50-year-old patient with epigastric pain, no vomiting, no diarrhea. Again, while we are worried about more likely gastric problems, we also have to exclude an AMI, right? 23-year-old cough and sore throat. Now there's a flu epidemic. Never mind.
Yep.
Right? But when you have a 76-year-old man, also headache, sore throat, then we also think of things like, could this person also have meningitis?
Yeah, given his age, and we need to look into his comorbidities as well.
Correct. If he's a diabetic, there's meningitis also in the back of our mind. Okay, so back pain in a 21-year-old army boy, again, we are not that worried.
Yeah, shouldn't be there.
Yeah. Heel pains for 4 months in a young person, probably
Fasciitis, yeah.
Yeah, fasciitis. So you see, this is how we use. We use heuristics to help us sort out our cases and pick up those whom we think should be brought to the front of the queue or have additional investigations. Right. Otherwise, we can't survive,
That's
Every day
right.
there's so many patients. But medicine, it's a wide spectrum. And in the ED, where many of our patients aren't structured, you have to use a lot of intuition, okay? Whereas the rigorous scientific study, those trials that you carried out, those is very controlled and well structured. So of course, most of the time you will have your diagnosis and treatment plan well made. So in between, I would say this is like polyclinic and the ED.
Right.
This is more like the SOCs, and this is the wards, right? And this is finally a scientific trial.
Right.
And for us, we always dealt the blunt end of the stick, because this is a very difficult area to work in. When you have to be around a target every time in an uncontrolled situation like the ED, certain cases will lead to systematic errors or cognitive biases.
Right.
And that's where you can cock up. Okay, let's look at this again. 45-year-old man fell down, pain. Again, the hip is painful, leg is shortened, externally rotated and adducted. I just happened to walk by. They asked me, what do you want to do? And I would
Hip X-ray,
hip
that's the
X-ray,
first thing that
right?
would come to mind.
Remember that very first, one of those first few we saw?
Yep.
Okay. So I was expecting this. Instead, what I got was this. It's a shaft fracture of the femur of the shaft fracture.
Right.
Right, and it looked, the way the shaft had displaced, it looked like shortened and still rotated. My fault, I didn't take off the blanket to examine the hip,
Okay.
because I was using a heuristic.
Right.
But on top of that, look,
Yep.
yeah,
Yep.
lytic lesions. Turn out
Lots of them.
that this patient is actually having lung cancer.
Oh, okay.
Okay, so that's where it went wrong. Now this is another one. Okay, not mine, but the neurologist. So this boy had actually presented to the neurology clinic.
Right.
Okay, and the neurologist, a lady neurologist, was working up this patient. Okay, bilateral arm weakness and numbness and paresthesias. and she was thinking of things like synovial, something happening in the
Spinal
cervical
cord,
cord.
yep,
Right, cervical cord, right?
Right.
And she was thinking of cervical cord because the lower limbs were spared. There was no sphincter incontinence.
Right.
Sensation was normal from the waist down. All right. So she was very interested, and she was starting to order CT scans of the C-spine. Then that time I was a MO who had just come out of the army and was beginning my internal medicine rotations lah.
Right.
And this was a neuro clinic, you see. So I walked in and she said, go, come and have a look at this interesting case. What do you think? They said, oh, army boy. So I asked the boy, what were you doing last week? Oh, I was having a road march and I was carrying my backpack.
Right.
And you were marching for more than 3-4 hours without a break? Yep. Then I shrugged my shoulder. I told my neurologist consultant, okay, case of bilateral brachial plexus palsy. You know?
Yep,
Now,
absolutely.
a neurologist using her heuristic, right, working on C-spine. After all, no, upper limbs are affected, lower limbs are spared. But I had seen it before. But this was an example where her heuristic led her up the wrong path.
That's right.
Another example, macrocytic anemia, polyclinic had worked her up for B12 and folate, but all normal. Okay, and blood film is macrocytic anemia.
Okay.
So of course they couldn't work it out anymore, so they referred to the ED.
Right.
So in the ED, looking at her like, what are these signs? What are these signs in the eye? And what is this in the neck?
It's a faint hint of a goiter.
Yeah. Goiter here and
Yeah. Some ptosis maybe on the left side, left eye.
yeah. And
Yep.
you can see all the sclera, right?
Yep.
In fact, if you look at the side of the eye, it's protruding out.
Okay. Proptosis.
Yeah.
Okay.
So what we are having here is a lady with Graves' disease
Right.
in the hypothyroid stage.
Oh, okay.
So I said, okay lah, no need to admit lah. Instead, no, I referred to endocrinology.
Right.
All right. Again, this is a patient. Okay, I have to use Western eyes because Asian eyes you just can't see.
Okay.
But the principle is the same, right? My medical officer who had been posted to the ED with me, for the past 3-4 months, we saw about 2-3 cases of glaucoma.
Right.
Okay, so one day I was busy with another case. The nurse said, there's this patient with a painful eye. So I told the MO, why don't you go and have a look? And if it is glaucoma, just refer to the eye clinic.
Okay.
Okay, so my MO said, yep. After examining the patient, came back to me and said, yeah, eye pain, mid-dilated pupil, blurred vision, glaucoma. I said, okay. Now in those days, this was in Toa Payoh Hospital. We had no eye clinic then. We had to refer to Tan Tock Seng Hospital eye specialist there.
Right.
So 2 hours later, Prof Adin Xiao from Tan Tock Seng called me up and said, hey, Siang Hiong, what are you doing? The case that you sent over is not glaucoma. It's actually a surgical third.
Oh, okay.
Yeah, and straight away you could understand, right?
Yep.
Both patients would have painful eye. But actually, this is retroorbital eye pain.
Right.
Okay.
There's no red eye.
Both pupils are fixed, dilated. There are subtle ptosis lah.
Right.
But because the patient was in pain and closing the eyes, my MO didn't exactly look for that. So again, he employed his heuristic.
Right.
He thought these had some features of glaucoma, and he treated as glaucoma. Okay. Oh, sorry.
Yeah.
Okay, so another example where heuristic went wrong. This was a real case in the middle of the dengue outbreak along Telok Kurau. This patient had come in for fever for 14 days. Okay. So the polyclinic doctor had done platelets. Says, oh yeah, platelets 56K. Okay. So I was looking at CLMM. I looked, yep. Fits with dengue. Everyone from that area is having dengue. But then a small fine print at the bottom of the report, blood cells seen. And this was added in after the polyclinic had referred the patient here.
Right.
Okay, and we could have missed that. So it turned out to be a blast crisis.
Right.
Again, another heuristic. So all this shows us that heuristics do have pitfalls. And if you are a senior vetting a case, then applying heuristics is a risk because we depend
Yep,
on the MO to be our eyes and ears.
Mm-hmm.
Okay, so like the glaucoma case,
Right.
both of us will let up the wrong part.
Correct.
Okay, then like a dengue outbreak or mini mass disaster, when you got many background noise, a lot of patients appearing the same way, you can get lost. You know, like the AML.
Yep.
Turned out to be we thought it was dengue.
Mm-hmm.
Never apply heuristic in elderly patients. That's all I can say.
Right.
You know why,
That's
right?
true. That's true.
Yeah, you know why, right?
Mhm.
They got so much pathology and they all appear atypically. Old lady with pneumonia can appear confused without fever. An old lady with ruptured appendicitis may appear like acute retention of urine.
Yeah, that's right.
Okay, then of course the anchoring bias lah. You know, he said, she said. If a GP writes in a letter saying, please see this patient who is a case of AMI, you know, and then straight away you, okay, maybe that's not so bad. You know you have to rule out AMI.
Right.
But sometimes a GP say, okay, perianal mass with bleeding, pulse.
Right.
Alright. And you're very tempted to just write it off and eyeball it and say this is pulse.
Right.
But now and then we get caught out by anal cancer. You know, so always be careful what people say, especially in handovers.
Right.
If someone is handing over to you, I remember my friend Prof Eileen Xiao, she always say, never trust the person who hands over to you. Check and double check. So, do I abandon my cherished heuristics? No, all this personal database. No.
The answer is no.
Yeah.
Yep.
Instead, we got to learn its limitations. And here is where I recommend this article strongly. Okay, so Davis Jacks from University of South Carolina. In this article, they said there are some heuristics that could lead us up. One of them is so-called availability heuristic.
Okay.
Alright? For example, you know, many factors will affect how you can recall a particular instance. Right? So, for example, in the epidemiology case, dengue outbreak.
Right.
Now I know whenever I see a dengue outbreak, I always scan the bottom for fine print saying that they have blast cells. Medical legal cases, you know, you've been bitten one, you could have lost some money, lost your reputation. So whenever you have a medical legal case, you become extra careful.
Right.
I remember I saw one prisoner, right? He was punched in the chest. He came into ED complaining of breathlessness. We did a chest x-ray, we did ECG, nothing found. Okay, so I was preparing to send him back, but he kept complaining of breathlessness. Right. But no, SEO2 was good, 100%. So I sent him back. A few days later, a colleague said, you know that case you sent back? Yeah, came back in DKA.
Oh, okay.
So from now on, any patient, I got in trouble, you know.
Yep.
So from now on, any patient complaining of breathlessness, I would always say, do a blood sugar. Could this be DKA?
Right.
Right. And near misses. Other people's near miss, you know, you always want to cover and make sure it don't happen. So if very heuristics may teach you to be more cautious.
Right.
But again, it may also make you over investigate in certain cases.
Right.
Then of course representative heuristic, what we call in common language stereotype.
Right.
Right. So menstruating female who had chest pains after arguing with husband, what would we be thinking of?
Yeah,
If we
nothing much probably. Stress.
Yeah, stress, anxiety, hyperventilating, right?
Yep.
And now and then, however, we pick up someone who has an AMI.
Yep. True enough.
True, right? Hyperventilating student during an exam.
Yeah, that's common.
Common. Yet now and then we pick up a few DKAs or asthmas, you see.
Right.
So our stereotypes, while it may be correct most of the time, we got to know its limitations too. And then another heuristic is actually it's an error, a fundamental attribution error. Okay, where we attribute the failure or success of another to internal characteristics of that person rather to the external factors. To make it simple, let me show you an example. Obese elderly lady coming with knee pains and swelling after walking.
Right.
Your first thought would be?
Osteoarthritis.
Yeah, osteoarthritis on
Yep.
the knees, right?
Okay.
So in this particular patient, I was also thinking the same thing. And yet a few days later, it turned out to be pulmonary embolism due to the DVT.
Okay.
She had bilateral
That's
DVT.
shocking.
You know, so but because we thought it was a big elderly woman with OA knees, documented OA knees, no, it just goes down that path, right? And this is another interesting paper, from Singh and his team at Baylor College,
Right.
just came out this year. Miss and erroneous diagnosis common in primary care visits. So it's very similar to our ED. And he found that the majority of it involved the patient-practitioner clinical encounter.
Right.
And this way our heuristics played us out. Or it could be stemmed from referrals,
Yep.
the GP or the referring doctors, he said, she said, it leads us down the wrong path. The other factors are usually system factors, computer errors. All these we can work at improving the system.
Right.
But for 1 and 2, the majority of such things, you can't improve the system much.
Right.
Okay? Alright. So, Singh and his team, they suggested that it could be due to a drop in basic clinical skills and related cognitive processes. They also thought that maybe shortened visits, just like the ED where we have time pressure, all this could cause problems.
Certainly.
Alright, right. But one habit he recommends is that we don't just stop at one diagnosis. We should develop a few differentials.
Right.
And I think this is the most important point. Develop a few differentials.
Couldn't agree more.
Yeah. Okay. So think about how we think. Seymour Epstein, okay, he's one of those who said there are 2 ways you should think: a fast and a slow one. Okay. He called this the cognitive experiential self theory. The long and short of it is that at some times we consider issues very rationally and logically and deliberately. At other times we just let go and think of it emotionally. So if you look at it, then heuristics are part of a larger experiential processing system that's adaptive but vulnerable to error in situations that require logical analysis. Okay. And Cross Carey, I had the opportunity to listen to him in Dublin in IFAM last year.
Right.
He put this in medical terms. In his article, Epstein's theory of slow and fast thinking can be divided into type 1 and type 2 ways of doctors' methods of thinking.
Right.
Okay. And this is a typical one. I know. Fast. Usually, we don't have to do much. We just observe the patient. It's very automatic. Okay. But the error rate can be high.
Right.
And while there's low effort, there's also low scientific rigor. Okay. And one thing is very emotional. I know you ask us to abandon our heuristic. You find it very hard to do so. I remember when Ottawa ankle rules came out.
Yep.
I was like, no, I don't want to, let go of my heuristic about when to order X-ray.
Exactly.
But in the end, I got no choice.
Right.
Because Ottawa ankle rule is an example of a systematic analytical analysis. The slow thinking is active. You can't be automatic. All right. It's slower. Okay. For example, many of our protocols is slow, right?
Yes.
And a lot of the time you're saying, oh, why are these protocols there? They are slowing us down. But actually, they are meant to be safe.
Right.
Okay. So you have very low emotional attachment. If they ask you to abandon it, you probably won't mind.
Okay.
For instance, right, the pneumonia severity index, right? So many things to score.
Yep, it's impossible.
Yeah, we always say, what's the difference between pneumonia severity index and the clinical gestalt of a senior clinician? I always felt that we could perform just as well.
Yep, agree.
Okay, so Cross Carey, he drew this rather complicated diagram. Just look at the first part, pattern process, recognize, and this is a heuristic, okay, and you make the diagnosis. So this is a path of a heuristic. But you can notice, right, there are many things that can affect it. The age and the experience of the clinician, your mood at that time.
Right.
Right? If you are
Exactly.
calm, you are likely to be accurate. But if you are time pressure and agitated, may not be.
Yep.
Gender plays a part, personality plays a part, and a lot of it depends on your heart wiring, how experienced you are.
Right.
And this is the other one, which is usually how geriatricians, how internal medicine people think. Okay, the case fit no known pattern. They don't recognize it, so they have to think about it. All right, they have to critically appraise the patient, order tests rationally, and then come to a diagnosis.
Right.
Okay, so this is your type 2 process. So the bottom line is that while we are familiar with Miller's competency model, as we become more senior, we know how to do it, we show how to do it, and we do it to become a true master, you must also know when to think fast and when to think slow.
Couldn't agree more.
Yeah.
Yep. Mhm.
So, what habits should we adopt to know when we should think fast and to think slow? Okay, so one thing is like what seeing from Baylor College advocates you avoid anchoring. If it fits the picture, then fine. But if it doesn't fit, then you should develop differentials. Okay, don't have just tunnel vision.
Right.
And sometimes after you look at a case and you don't know what's going on, maybe it's good to refer to a friend, but without giving away much history or data.
Agree.
Right? Because otherwise you'll be giving him a bias.
Yep.
Right.
Unbiased second
Yeah.
opinion. It's good.
Yeah. Then clinical practice guidelines, well, they are there for a reason, and they are evidence based. So you will be protected if you use them, provided that you fit the, provided that you make the diagnosis accurately.
Correct.
Okay. For instance, using the D-dimer and the ultrasound to rule out DVT. You know that rule?
Yep.
But you've got to make sure it is really a DVT.
Right.
Okay. And finally, if the patient don't have a full-blown picture, don't just take on the diagnosis. You know, right? Many of our MOs get into trouble when they diagnose a patient with vomiting and abdo pain as GE. Then later turn out to be something like ruptured ovarian cyst or ruptured gallbladder. And why? Because there's no diarrhea. But because they had to label something,
Yep.
they call it GE.
Yeah. It's easy to do.
Yeah.
Usually it's wrong.
Yeah. I think you and I, we will have no worries. We will feel no shame. We will say, this patient has abdominal pain of unclear origin.
Right.
Right. But we would have said, we have already excluded certain things.
Right.
I don't know what's the pain or what's the cause of your pain. We can tell the patient. But we have excluded appendicitis. We have excluded renal stone. You are good at ultrasound. You could tell them I've excluded gallstones, you know.
Right.
So if you cannot make a diagnosis, as long as you tell the patient I've excluded important ones, the rest can be worked out as outpatient, I think we should be happy.
Yep. Agree.
Don't have to label things. All right. And finally, read. Okay. I myself, I like to read those case reports from MPS and MDU. They always teach you where people went wrong.
Right.
And I like to read it.
Yeah, learn
I
from
know that many
mistakes.
of them throw it away, but I collect them.
Okay.
Okay. Then you know your bottom half of symptoms and signs of any pathology section in textbooks.
Right.
For example, if you read the section on thyrotoxicosis, the first few lines are the classic symptom: heat intolerance, weight loss, increased appetite, right? For
Right.
thyrotoxicosis. But at the bottom half, there are things like high output heart failure, okay, organic brain syndrome, confusional state. So that kind of thing, atrial fibrillation, that kind of thing don't appear classically, but they do come to us in the ED. So we always have to know. Okay, and I like to read M&M rounds.
Right.
There are free lessons in errors, just so, and it can be quite interesting to learn from them as long as they are not your mistakes. So actually, the most important question is at the end of the day, not really what's the diagnosis, but for us in the ED is the patient safe to go home?
Right.
Okay, and we're only talking about making a diagnosis here today. We haven't talked about heuristics for treatment plans yet. Okay, I would recommend 3 books. One of them is Thinking Fast and Thinking Slow by Daniel Kahneman. There are 2 versions of how doctors think. Okay, one version is by Catherine Montgomery. This is more scientific. Jerome Groopman's one is the one that's better known, but actually it's aimed at the layman.
Right.
Actually, I would ask you to read this very critically. Most of his examples that he quote are, the doctor was wrong, but the patient insisted on the test being done. That's how the diagnosis was made.
Right.
So I think we cannot always be doing what the patient wants.
Right.
But as long as we have a judgment and we think it's relevant to order investigation or not, then that's good enough.
Okay.
So you can read this but critically.
Okay.
Okay. So finally, I want to thank you and Rahul and Mohan, who's always sending material into our staff mailboxes.
Alright, that's the end. Thank you everyone for listening, and thank you Prof Goh for giving this talk. Bye bye.